Good morning. I'm doing my presentation on inflammatory bowel disease, which consists of ulcerative colitis and Crohn's disease. Both of them are mainly common in young adults or adolescents, not super common in young children or even babies. And I'm going to go over the similarities and the differences and also how they're treated. Okay. So first up is Crohn's disease. Which is, again, most common in adolescents or adults. And it appears as patches throughout the GI tract, can be from the mouth all the way through to the anus. Most commonly, though, it's at the ileocecal, valve, the ileum there, and then into the small bowel. The terminal ileum is the end of the colon leading into the small bowel. And I guess the beginning of the colon where the small bowel leads into the colon, and that's your most common area, but you can see patches throughout the entire colon or small bowel, less common in the esophagus, but it could happen. The exact cause of Crohn's disease is unknown. There is some research to suggest that genetics could play a significant role in this, is if you have a family history of anything that's ever, if anybody's ever had Crohn's disease or any type of inflammatory bowel disease, it puts you at a higher risk of also developing that. Signs and symptoms of Crohn's disease could consist of diarrhea with what's called occult blood. Occult blood is hidden blood in the stool, so if you're having bowel movements, you may not see it or even notice anything. You wouldn't notice any black or tarry stools. But if you go to the doctor and say that you're having diarrhea, they may, in the office, do what's called a hemoccult card, where they smear some stool on there and some of the activator, and it'll let them know if there's any hidden blood. You can also have blood work done at any type of lab, and they can also see, test it and see the same thing, for any hidden blood. You could have some moderate to severe abdominal pain and or cramping. This is mainly seen in Crohn's, less in ulcerative colitis. There could be some abnormal weight loss, so you're still eating and drinking the same, but your patient could be losing weight for no apparent reason. So that could be a sign as well. There's also what's called perianal fissures or fistulas, which are little tunnels that you can see on the anus, and they lead into the intestines. It could cause major infections. They're very painful, especially when having bowel movements. It's like a cut. It's very sore, very painful. And they are not very common either. So for ulcerative colitis, this is continuous inflammation throughout the colon. So whereas Crohn's, there would be patches anywhere in the GI tract, this is mainly found, ulcerative colitis, mainly found in the colon, and it's a continuous inflammation that you'll see, rather than the little patches everywhere like Crohn's. It'd be just a continuous inflammation that the doctor could see when doing a procedure. And ulcerative colitis only affects the innermost intestinal wall layer, where Crohn's can go deeper throughout all the layers. So causes, again, of ulcerative colitis, very similar to Crohn's. The exact cause is not known. Again, research would suggest, genetics. Again, if you have a family history of any IBD, especially ulcerative colitis, you could be at higher risk for developing it as well. There is some research that suggests that foreign antigens in the air, our bodies can produce an inflammatory defense, and this could possibly not subside and lead to ulcerative colitis or Crohn's disease. Just very little research to defend that, but could also be a possibility. So signs and symptoms of ulcerative colitis, they are different than Crohn's. With ulcerative colitis, you're going to see frequent bowel movements, 3 to 20 a day. Could be more than 20, but usually your range is 3 to 20, but they're going to see blood. It's going to be diarrhea. They could be seeing bright red blood. Dark stools are also a sign of blood, so there is that possibility as well, but they're going to know that something is wrong because of these stools. If a patient's doctor orders any blood work and it comes back that maybe they're anemic, maybe there's something in the GI tract that's taking away the blood and causing them to lose blood. Again, the bloody diarrhea, you're losing blood, that will make you anemic. That will also cause an electrolyte imbalance. Again, another cause of ulcerative colitis. Same thing with Crohn's disease. You can have a significant unexplained weight loss. So if you're having if a patient's having unexplained weight loss, there could be more than one reason, but it's a sign of inflammatory bowel disease. With ulcerative colitis, you could develop rashes, you can have a fever, because that inflammation, your body's trying to fight off the inflammation, develop a fever. And you can have joint tenderness, so like an arthritic type of pain, because this is inflammation. You could have the inflammation in your joints as well, so that could be a telltale sign of ulcerative colitis. So testing for ulcerative colitis and Crohn's, there are some similar testing. For Crohn's disease, a doctor could order an MRE, which is an MR enterography. It is like a really fancy MRI. It takes a very good look at your small bowel and can show if there's any, again, patching in there for Crohn's disease. Other testing could be like blood work, stool samples. Again, the stool samples, you can look at the hidden blood, so occult blood. Blood work, CBC is your hemoglobin and hematocrit for any blood loss. You can also order like an iron panel to see if we're losing blood, like an iron deficiency anemia. And so you can also have a colonoscopy or an EGD. The colonoscopy looks at the entire colon, goes all the way to the ileocecal valve, terminal ileum. That area does not reach the small bowel, but we'll look at the colon to see if there's any inflammation. And the doctor would take biopsies to be sent off to see if there is any inflammatory bowel disease going on there. In EGD, the scope goes into the patient's mouth, down the throat, through the esophagus, into the stomach, and then into the duodenum. Again, there could be biopsies taken looking for any inflammation or signs of IBD, because remember, Crohn's disease can be from the mouth to the anus. There's also what is called a video capsule endoscopy. That is a little pill that has a camera in it, and the patient would swallow that, and that would really take a good look at that small bowel that is missed by a colonoscopy and an EGD. It will look, again, your Crohn's disease is mainly going to be in your small bowel, but could be looking for any source of anemia as well. So treatment for ulcerative colitis and Crohn's, there's 5 categories of medications that are used for both. And normally it's just a matter of where is your disease, how severe is it, so what medication are we going to use? So the 5-ASA group, that is a rectal medication. So if the patient is having ulcerative proctitis, which is in the rectum, you could use a rectal suppository in the 5-ASA category to help reduce that inflammation. Corticosteroids are topical, oral, and IV. These are mainly for severe cases that you would probably give a patient orally or through IV because they're having a severe flare of their disease, or maybe they just got diagnosed and it's very severe. We're going to want to treat them with that. Antibiotics, for inflammation, orally or IV. Immunomodulators are oral or by injection. And then you have biologics that are IV or injection. Those are moderate to severe cases for a biologic. A lot of times patients will go on those and they'll be on a 6 to 8 week regimen with those infusions. And that is all I have for IBD. Again, ulcerative colitis and your Crohn's disease are your inflammatory bowel disease, mainly seen in young adults and adolescents. I hope you all learned something today. Thank you.